Good afternoon, dear colleagues and dear audience. Please let me introduce my PhD topic and progress so far, which is about the effects of maternal factors on the development of orofacial clefts. My name is Márton, and currently I'm a first-year resident doctor at the Department of Oromaxillofacial Surgery. You can see my 3 ongoing projects. 2 of them are meta-analysis and 1 is a registry analysis. The first project is about investigating the effects of deleterious habits and maternal health disorders on the orofacial cleft development. It is a systematic review and meta-analysis. So we know that these orofacial clefts are quite common birth defects with an estimated worldwide incidence of around 1.7, 1.8 per 1,000 live-born babies. And the babies born with these types of anomalies have feeding difficulties, they might have hearing loss, several dental anomalies, and speech problems. And we know from the literature that maternal diseases during the first trimester of pregnancy are shown to play a role in the development of orofacial birth defects. So that is why our aim in that study is to identify those maternal risk factors that might increase the orofacial cleft development. We have the clinical question, do maternal health disorders and deleterious habits during pregnancy increase the risk of the orofacial cleft development? We use the PEO framework where our population is pregnant women. The exposures were like maternal risk factors such as smoking, alcohol consumption, hypertension, and our outcomes are prevalence of cleft lip and palate and cleft palate only. And why is it important? Because using our results, these orofacial clefts will be diagnosed to a greater extent, and mothers in the first trimester will be more actively treated in order to prevent these anomalies. You can see our systematic search here we conducted on the 3 main databases. And at the end of the whole selection process, we had 64 eligible studies for the analysis. So let's talk about the results. Our first figure shows the effects of diabetes on the development of orofacial clefts. In that forest plot, we compared mothers living with type 1 diabetes versus those who were not. We calculated odds ratios here with a 95% confidence interval. And as you can see, we used 3 subgroups according to the different types of cleft lip and palate. The first is the cleft lip and palate. The second one is the cleft palate only. And the third subgroup says not defined, which means that in those studies, the authors did not mention which type of clefts were the babies suffering. And at the end highlighted, you can see that our overall odds ratio was 1.75, which is statistically significant, and it shows us that there is a 75% greater chance of having a cleft baby in case of the mother is living with type 1 diabetes. The second figure is about the effects of underweight on the development of orofacial clefts. Here we also use the 3 subgroups that I mentioned before. And the overall odds ratio was 1.21, which is statistically significant, and it means that there is 21% greater chance of having a cleft baby if the mothers are underweight during the pregnancy. The third figure is about the effects of smoking on the development of orofacial clefts. This forest plot is a little bit different compared to the previous ones. We used 2 subgroups here according to the different types of smoking, active smoking and passive smoking. And in that slide, you can see the active smoking part. And the second slide is the passive smoking part. And as you can see highlighted below that the odds ratio is 1.5, which means that there is 50% greater chance of giving birth to a cleft baby if the mothers are smoking during the pregnancy. The fourth figure is about the effects of obesity on the development of orofacial clefts. Here we use subgroups according to the different types of or different BMI indices. And although these results were not statistically significant, but it means that there is a tendency that in case of the mothers are suffering from obesity, there is a 31% greater chance of giving birth to a cleft baby. So what are the strengths of our study? We use subgroups according to the cleft type, which is quite unique compared to the previous meta-analysis on the same topic. We investigated more exposures, and we have a relatively high population. Although in some cases we had low number of articles and high risk of bias in some cases. So in conclusion, we can say that diabetes, underweight, smoking significantly elevate the risk of cleft development. And as I mentioned, passive smoking might be as harmful as active smoking according to our results. The implication for practice is, for example, nutrition, plasma glucose level should be carefully monitored during the pregnancy, and more effective and comprehensive prevention programs against smoking are needed. And the implication for research, it would be interesting to investigate the synergistic effect of these exposures. And also, we still don't know what is the development, what is the difference between the development of the cleft palate only and cleft lip and palate. So you can see the status of the first manuscript we submitted to the scientific report. And my second project is a registry analysis. It is investigating the effects of pharmaceutical therapies during pregnancy on the risk of orofacial cleft development. So we know that 14% of pregnant women filled at least one prescription for an opioid analgesic during the first trimester in the USA. And the odds ratio of developing cleft after the use of anti-epileptic drugs is 6.6, which is quite high. And maternal corticosteroid use was also associated with the increased risk of cleft lip with or without palate. So that is why our aim is to identify those medications that increase the risk of orofacial cleft development. So a few words about the whole registry. It is the Hungarian Case Control Surveillance and Congenital Abnormalities. It was established in 1980, and this professional network was led by Zeisel. They thoroughly analyzed the data of these 17 years, and more than 800 scientific papers were published based on the database. The data collection was between 1980 and 2009. The question is, do medications during pregnancy increase the risk of cleft development? The framework is also the same, the PEO, although here the exposures are medications like antibiotics, anti-epileptic drugs, opioid, folic acid, and the outcome is also prevalence of cleft lip and palate and cleft palate only. It is important to identify those medications that should be avoided during pregnancy in order to decrease the overall incidence of orofacial clefts. The eligibility criteria were cases with congenital anomalies. The exclusion criteria was cases reported after 3 months of birth or pregnancy termination. 3 mild congenital anomalies were also excluded, and those syndromic congenital anomalies. The controls were defined as newborns without any congenital anomalies, and in most of the years, two controls were matched to every case according to the sex, birth week. Although after 1992, the third control was left due to insufficient final support. 3 types of data were collected: prospective medically recorded data, retrospective self-reported maternal information, and supplementary data collection by the nurses. The types of collected data, so what's important to us, you can see highlighted. It will be the drug intake during pregnancy, according to pregnancy months, and also the believed protective factors like multivitamin supplementary intake and folic acid will be also included in our analysis. You can see the results here. So altogether in this database we had nearly 90,000 patients. And you can see on the right side highlighted that what outcomes are important to us, the different types of cleft lip and palate. We have around 3,000 patients with these anomalies. And you can see the 3 recent articles based on this database. And my third project is about investigating the effects of pharmaceutical therapies during pregnancy on the risk of orofacial cleft development. It is very similar to the previous one. Also, it will be a systematic review and meta-analysis. The clinical question is the same, that do medications during pregnancy increase the risk of the development of orofacial clefts? The PEO framework is just the same as in the previous one. And also, it is important to identify those medications which we should avoid. And it is in the early phase of this project, since we were focusing on the first 2. And to summarize, you can see the 3 projects. And as we submitted our first manuscript, we are planning to put more effort and more energy into the second project, the registry analysis. Translational activities, recently published article was published by my sister based on the same topic, and I was a co-author in that manuscript. And science knows no country, because knowledge belongs to humanity and is the torch which illuminates the world. And I would like to thank you for your kind attention.
Thank you for your nice presentation and congratulations for that. My question is regarding your first project. What are the reasons for the high risk of bias?
Yeah, so in all these studies, there were several confounding factors. Also, I can mention the socioeconomical status of the mothers, and in some articles or in some studies, they were not as precisely investigated as it should be. So that's why the reason we have, in some cases, high risk of bias because of the confounding factors.
Thank you.
Thank you very much for your presentation. Actually, I have two questions. The first is, could you put these odds ratios from your first project more into context, like the prevalence of orofacial malformations in the control, like unexposed population versus the exposed, in percentages, I mean?
Can you go back to the slide? Yeah, sure.
Just because I'm always curious, like this 1.75 seems like way too high, but what if it means from 0.1 percentage to 0.12 percentage, like in percentages, like in prevalence?
So I mean that, as I highlighted that, for example, if the odds ratio is 1.21, that means that it is statistically significant and there is a 21% greater chance of having a cleft baby, for example, in that case, if the mother is suffering from underweight.
Okay, I meant practically. My other question was, like, usually, because I work with similar data, these odds ratios are not crude odds ratios. They are adjusted for maternal age, sometimes ethnicity. So were these, so in your case, were these adjusted odds ratios? If so, which factors were used for adjusting?
Yeah, so it was different in the studies. In most cases, they were adjusted odds ratios, and in fewer cases, they were just crude odds ratios. And these adjusted odds ratios was adjusted according to the maternal age, the socio-economical status, the sex of the baby, which is also seems to be important in orofacial clefts.
My question is regarding this project. Where you are showing the forest plots, you said that there is a whatever percentage increase in the chance of being born with clefts. In these slides, the control group means that there is no presence of, like here, underweight, or there is no other risk factors neither?
No, in that case, the controls or the control mothers were not suffering from underweight. Of course, this is also a confounding factor that we actually don't know whether these mothers were just were not underweight, but they were several other confounding factors like the socio-economic status, and maybe they were smoking. But on these forest plots and on the individual analysis, we only focused on the exact risk factors. So in that case, the underweight.
Marci, thank you for your great presentation, and I would like to congratulate. I have not a statistical question, but you mentioned that on the slides we could see that in passive smoking we have a higher odds.
Yes.
And did you found any information behind that? What is the reason that after your data it seems more harmful than?
Yes,
than the active smoking. So
this was also interesting for us, and this is one of the message, the main message of our manuscript. Yes, maybe because that might be because, as you can see, compared to the active subgroup, we have several articles, but only in the passive smoking we have, as I see, 6 or 7 articles. So that might be a bias that we have a low number of articles. And these studies mainly from Asia. And we know from the literature that in the Asian region, the overall prevalence of cleft lip and palate is much higher compared to the any type of the region or any regions of the world.
Mm-hmm. Thank you.
But this also needs more investigations. That what might be the reason that that passive smoking could be just as harmful or more harmful than the active smoking. Yeah, and it was quite interesting for us as well.
For me also, thank you very much.
Congratulations for your presentation. I just have a quick question regarding this slide. Do you know any particular reason why the last 2 studies in this analysis have such a huge difference between odds ratios compared to the other studies?
Yes, as you can see, that they are clearly outliers in that forest plot. As you can see, we have a relatively small number of participants in that study, and this last one was one of the articles that we mentioned in the main manuscript, that there was several high risk of bias. They did not investigate any other confounding factors. So we have to take care of these, or we have to handle these articles or this article very carefully.
Let me jump back a little bit with this secondhand smoking. Do you know any? No, it's fine. It's just theoretical. Yeah, it's very clear from the forest plots. But do you have any other disease which might be more prevalent for secondhand smokers than the real smokers? Is there any other disease, like lung disease, is equally affecting the smokers and the secondhand smokers, or is there anything different between these?
Yeah, well, this is also confounding that, for example, of course, it's passive smoking or active smoking, but we don't know what else other diseases these patients have. And we presume that those mothers who are smoking, they might develop any other diseases during the pregnancy, maybe because of the smoking, but we don't know that the orofacial cleft is because of the smoking or because of the evolved disease during the pregnancy.
Okay, but lung disease is affecting more the second-hand smokers or the primary smokers?
Yeah, the primary smokers.
Or more? Okay, I don't know.
Sorry if it seems a silly question. I mean, how novel do you consider your results? I mean, didn't we know already that smoking is bad for pregnant women? I mean, I'm sorry. I'm not mocking you. How could you translate your results, like these odds ratios, because like it's a quantitative synthesis, as we say, into your future practice, your everyday practice? Like, what would you do otherwise from tomorrow? Because my view is that when somebody decides on having a baby, like the uterine environment and like the whole body itself was exposed, like, for example, smoking for years. Okay, what does it change? Like, if tomorrow I quit smoking, does it really make a difference for my developing baby? I mean, what's your thoughts on that?
Yeah, so that's a very reasonable question. And as you can see, it is a well-investigated topic, the smoking, as you can see the several articles which we analyzed. And there were several previous meta-analyses based on the effects of smoking on the development of orofacial clefts. So that's why our main message is not about the smoking, because it was well investigated previously. Also, what's important and what's interesting for us as well, and it was not investigated in the previous meta-analysis, is the passive smoking. So that's very new to us as well, that this passive smoking might be as harmful. And also, I think everybody knows that smoking is bad for the health and also for the pregnant women, but we did not know that passive smoking might be as harmful as just the active one in case of the orofacial clefts. That's why I said that more comprehensive programs against smoking are needed, and also we have to tell the patient that it is also very harmful for them if, for example, anybody in their household is smoking, although they are not actively smoking, but it can be counted as a passive smoking. So that's why, for example, more programs against smoking are needed, and we have to tell that mothers that also they are not smoking. It might be harmful that anybody in the household smokes around them.
That's what I was also interested in. How do we define passive smoking? Like, I just sit down at the terrace of a bar where it's allowed to smoke, or I mean, especially those studies, could you just name one definition of passive smoking?
Yeah, that was also confounding, and that was problematic for us because these studies did not describe passive smoking as precisely as we believed or as we wanted them to describe. As far as I remember, the first article was the only one which mentioned that what do they count as passive smoking, and it was that anybody in the house or who they are living with is smoking, although the mothers are not active smokers. But that was problematic for us as well, that they did not describe precisely.
This is very complicated, or I wouldn't say complicated, but imagine that you have a child who have this cleft palate, and then you are the mother, and then you have to report this. So that's easier to report than other people in the family do smoke, than reporting that that is my fault. So therefore, there is a general bias on top of this, probably actually underestimation in many ways, because many of the mothers didn't say that they did smoke during this. So I mean, all these studies are very, so we have strong limitations. The other thing is most probably that there are no studies actually on the cumulative factors, on high blood pressure, and then you may explore on this actually, that this would be very important.
Yeah. So just as I mentioned, it will be interesting to investigate these exposures together. For example, if the mothers are obese, they might have also diabetes and also hypertension. That's an implication for the further researches to investigate these exposures together.
I have one question regarding your second and third project. I saw that you would like to investigate the effect of folic acid as well. And as I know, it has a preventive factor. And why do you want to investigate in these studies?
Yeah, so as we know that, and as I mentioned, that folic acid, multivitamins, the B6 and the B12 vitamin seems to be a protective factor in congenital anomalies, also orofacial clefts. But as far as I searched in literature, only just a few studies that showed or actually investigated the protective factor, and only just a few of them which showed significant results especially on the orofacial clefts. So that's why we decided to involve in our registry analysis, and we have the data for that.
I also would like to congratulate your nice presentation. So how sure is that you are investigating only one etiologic factor, because clefts are a multifactorial disease. So for example, if smokers fly more frequently, and we know from Japan to New York it means 800 microsievert gamma ray irradiation. So how sure is that you only investigate that isolated factor or something in the background?
Yes, that's a perfectly reasonable question and comment, that it is also bias and confounding factors that, okay, we're investigating just one etiological or environmental factor, but actually the studies did not mention that what was their lifestyle, how much they were traveling by plane, or in which region of the world they were living. For example, that might be the reason that in Asia it is much higher, because the air pollution. So that's what we couldn't take account in our analysis, because the studies did not mention that.
Yeah, thank you. And how would you summarize your message to the clinicians who are performing clinical trials? So what would be more precisely described in such studies for better analysis? So only two aspects. What is your message to them? How they can improve their work?
Yeah. So for example, smoking is a bad lifestyle habit. So it would be good if we could influence that. But for example, in case of the diseases like obesity, the diabetes, the hypertensions, it would be so good to organize more recalls and more maternal investigations by the clinicians, and actively treat these diseases that might increase the risk of orofacial cleft development.
Of course, we are at midterm now, so I will ask everybody probably, what is your plan for the next 2 years? How will you finish all these projects? What would be the main emphasis of these 2 projects you are suggesting now? How do you see your timeline?
Yeah, thank you. So we published this first article. So as we are waiting, we can focus more on the second project. So as we have data, we will soon organize a meeting with the statisticians and make the plans. And I hope that that we can finish it quite soon. And then focusing on the third project, which will be just the same as the second one, although it will be a systematic review and meta-analysis. But it will be a little bit difficult, and we were making plans and having discussions with my supervisors that to actually which medications should be involved in that meta-analysis. We were thinking about, for example, focusing only on the antibiotics or the anti-epileptic drugs, because we have several medications in the literature. So that's why it'd be quite difficult, but I hope that we can now go on and start the second project and work on that.
Okay, thank you. Any other? By the way, Zeisel has developed his formula of vitamins on the basis of this registry. Do you know that, or the results of .800 paper, or was it from somewhere?
Whether it was this, but I'm pretty sure that it influenced him.
Okay. Yeah. Thank you.